The current state of Lyme diagnostics in Canada by Dr. Hatchette.
Thanks. So thanks for the conference organizers for inviting me. It's been actually quite informative. I'm going to go through my presentation, which is going to be a lot of stuff that we had heard about this morning, but hopefully will put you in more of the Canadian context. And at the end, I'm going to read something that I wrote about 4 o'clock this morning because I was thinking a lot about the patient stories last night and tried to frame what I was taking away from what I was hearing. And hopefully I've captured it, and if not, I'm sure you'll let me know. I do have some grant support from GSK and Pfizer. I oversee the diagnostic testing for the Severe Outcomes Surveillance Network looking at community-acquired pneumonia and influenza. I did receive an honorarium for talking about latent TB infection and reactivation in biological therapies, but I don't have any consulting fees. Funding for the research, the honorarium that I had nothing to do with Lyme disease, so really there's no bias from that perspective. I will declare that I am the co-chair of the working group looking at Lyme disease diagnostics for Canada as part of the provincial public health laboratory group. So I think a lot of people have talked about definitions, and from a laboratory perspective, it's very important to clearly define who you're testing, because the testing and all of the data that we generate through the tests are based on who we're testing. So you need to, the validations we go through need to be clear on clearly defined cohorts. So we've already heard about localized Lyme disease, disseminated Lyme disease, the late Lyme disease, the post-Lyme disease syndrome, and then chronic Lyme disease. And within the chronic Lyme disease, we've heard it's been divided into two. There's the ones that have been diagnosed with alternative diagnostic methods, we've heard through IGeneX, and the other one where all the tests are negative but are diagnosed clinically. So again, this is just a very short summary of some of the manifestations, clearly not all-encompassing, but just to divide sort of the framework in terms of early localized is days to weeks, disseminated is weeks to month, and then late is months to years. And this is just a slide that kind of shows that with time and some of the typical manifestations. So the acute cutaneous disease, you say that over 75% of patients can have them. That was in clinical trials, really, that were dedicated at following patients very, very closely as part of vaccine trials, and may not be that high in routine clinical care. Disseminated disease can be neurologic as well as carditis, which tends to be less frequent than the neurologic disease. And then the late disseminated disease, the predominant one that we see in North America, at least that's reported in the literature, is arthritis, with neurologic disease occurring less frequently, but you can see that it can span multiple time points. No, I don't have to go over any of that, given that most of you already realize that. But what the factors about diagnostic testing that people need to remember are, one is the type of specimen. So are we dealing with blood? Are we dealing with urine? Are we dealing with CSF? The collection time in respect to the disease state will help define how well the test is in terms of its accuracy. The kinetics of antibody expansion, so how the body responds to the pathogen, will influence how accurate the tests are. The methodology, so is it PCR, is it culture, is it serology? And then the bacterial strains. We've talked a lot about the strains in North America, but if you travel to Europe, those strains are different, those Borrelia strains are different, and our testing may not pick up those particular strains. And then the prevalence of disease, which we heard a lot talked about by Dr. Patrick, will influence the pretest probability or the positive and negative predictive values. So those are all the things that we think about when we think about diagnostic testing. So what we currently do in Canada, we do serology, we do the two-tier algorithm. You guys are all aware what that is. I will show you exactly what each public health lab in the country is doing later on in the slides. PCR is offered for synovial fluid and for CSF. That's done in a couple of the public health labs, but mainly done in Robin Lindsay's lab at the National Microbiology Lab. Culture is not really done in Canada. It tends to be a specialized test. It's not that sensitive, but obviously when you get it, it's helpful. Tests of uncertain performance. So there is the urinary antigen detection, which some people have talked about. There is not a lot of good data to support its use at this point. The CD57 is another one that is mentioned, NK cells, and there is not a great correlation there. And then the ELISpot is gaining some traction. Certainly some of the early ELISpot stuff, the sensitivity was not high, but we heard from Dr. Detweiler today that he's working on that, and hopefully that may be something that will be used in the future to help us diagnose not only earlier clinical disease, but help with treatment and who needs ongoing treatment. But at the moment, it's not part of the mainstream testing. So, Western blots cannot be used independent of the EIAs, and that's because they have poor specificity. So the IgM Western blots will be false positive if used alone. And we show, Dr. Detweiler did show some data there, particularly with his two-dimensional gel, how some of the other bacterial antigen or antibodies that you get to other bacterial antigens may mimic areas where you would see the same pattern for Lyme-specific stuff. And of course, European species can be falsely negative on the North American Western blots. And we always advocate to physicians, if they have a person who's traveled in Europe, that clinical history is important for us to know so that we can forward it on for the proper testing. This is a very busy slide, but it just goes to reflect the different proteins that are on the Western blot. There are three colors there. The red and the green speak to sensitivity and specificity. The blue is a receiver operating curve, which is a statistical method to see how well it performs in predicting who and who doesn't have Lyme disease. And you can see that the sensitivity and specificity are variable for different things. VLSE tends to have the best performance in terms of sensitivity and specificity, but things like P41, for example, has a lot of false positives. If you have specific questions about this, I'm sure Robin will be happy to answer them in our question period. So the performance of the serology really does depend on the stage of the disease. And I'm sure you guys have seen this study before. It's from Alan Steer's group from 2008, where they followed people with culture-confirmed erythema migrans. They had a number of people with late Lyme disease or other illnesses, and they had objective clinical findings, and they had positive serology. So you're going to say, okay, well, they had positive serology, so already the population is biased. But this is what we currently have at our disposal now to validate new assays. So one of the things you're going to take away from this, hopefully, is that we really need to have our own well-defined cohorts in Canada. So if we want to change our recommendations, we need to have our bloods that we can do the testing on to make sure to show that that's a reasonable thing to do. They also had other mimickers of people who have a post-Lyme disease syndrome or chronic Lyme disease, as well as controls who are otherwise healthy. And you can see here, this again is not news. We know that this two-tiered system in particular does not perform well in early disease. Less than 50% of people will have positive results. But as the disease progresses, the performance of the test is actually quite good. And for arthritis in particular, it's very good. Now, disseminated neurologic infection, if you look at that 85%, a couple of those patients had more early neurologic symptoms, so they had things like Bell's palsy rather than the more later disseminated. Just as important as sensitivity is specificity. And you can see here that the specificity of the two-tier algorithm is high. You didn't get a lot of false positives in any of the healthy states, whereas if you just use C6 alone, you would. So that we've heard pleas for not abandoning the C6 or not moving to a single assay and not abandoning C6 because it has some importance. So this is a more recent study. Those were a well-characterized group. This is the CDC panel that they have. So they've realized that the validation of Lyme diagnostics is very difficult because we don't have well-defined cohorts. This is their attempt to do that by collecting sera from different categories of patients. So people with acute disease, convalescent serum, people with arthritis, and then people with other more late disseminated manifestations. In addition, just like any other validation that we would do, it's important to look at the specificity. So they had similar like diseases as well as healthy controls. And you can see here, based on this panel, and they used, you'll see the whole cell lysate, as well as the two-tiered system and the standard interpretation. Again, acute disease doesn't work very well. Less than 50% of people were identified, whereas things like Lyme arthritis, it works quite well. Lyme borreliosis in this one was 90% sensitive. So again, it depends on the stage of the disease. And again, it depends on where you're collecting your specimens from. But a lot of the earlier stuff, particularly showing that there was a lot of false positives and poor sensitivity, was on older assays that were more heterogeneous in their antigenic composition. So their proteins were the whole cell lysate. So you grow the Borrelia. We heard from Dr. Detweiler that when you grow the bug, you may not necessarily have the same proteins that it is when it's in your body. So they have looked at the various proteins and tried to figure out which ones are more accurate in the diagnostics. C6 was the first one. We saw that. There is recombinant VLSE itself, and then there's a new one called C10, peptide C10, which is portion of the outer surface protein C. And I'll show you some data that suggests that if you use combinations of these things, that the performance is actually a little bit better. There's also some other lipoproteins that are being looked at. Again, one of the things that Dr. Detweiler talked about was looking at combinations rather than our current status. And I think that that's probably where we're going to end up going. So this is from a review that was just published in the Journal of Clinical Microbiology. And you can see this kind of gives you the evolution of diagnostics within Lyme disease, going from the whole cell lysate to the two-tier system to the C6 ELISA, to the C6 ELISA used in a two-tier, to the VLSE, the C-peptide, and the VLSE and C-peptide combined. So the C-peptide tends to come up early in disease. It tends to be IgM focused, whereas the VLSE tends to be more IgG. But if you use both of those in combination, you can see that the sensitivity for early detection is actually higher than many of the other ones. It's at 67%, which is pretty good, and it increases as it goes across. And just as importantly, the specificity in healthy people is about the same as the current two-tier system. So there is some data that's coming out to suggest that things are going to evolve. But we can't make those recommendations without having the serum to really challenge them. What about alternative algorithms to the two-tier? Well, this study is a little bit old now. It's from 2011, but it looked at using the whole cell lysate and then the C6 as a confirmatory method. That showed better sensitivity and equal specificity on a small subset of specimens. Again, this VLSE IgG and the peptide C10 IgM done in a multiplex assay looks like it has very good performance characteristics. Again, small subsets needs larger in order for it to be validated from an FDA perspective. So this is the summary table that I'm sure you're all waiting for. This is what the various labs across the country are using for Lyme disease testing. So you can see that all of the labs except for Prince Edward Island and Newfoundland will do their initial screen in-house. PEI sends their stuff to us in Nova Scotia. Newfoundland sends it to directly to the National Microlab. Quebec has various ELISAs, including C6 and some of the newer ones like the VLSE. You can see that many of them use C6 in their algorithms. We use the combination of a whole cell plus C6. Of course, the theme with this is that they follow the two-tier recommendations, and any positive or equivocal specimens, any reactive specimens are sent to the National Lab for Western blot testing. I don't think I need to spend too much time on this. This is Brian Fallon's paper, which highlighted the fact that if you use alternative criteria for grading Western blots, you can lead to significantly spurious results. And again, 57% of healthy individuals had some indication that they would have said it was Lyme disease here. So it is, it's a problem. This is just some other new data just to remind people that just because a new test is out there doesn't mean that it should be used without proper validation. And as laboratory scientists, we're very, very careful about our validation because we have accreditation requirements that require us to make sure that the accuracy of the tests are true. This is a light microscopy method that was used to diagnose Borrelia in blood in Sweden, I think it was. And they found that 25 out of 41 healthy controls had positive microscopy. Again, speaking to the false positive potential of these assays. And when they tried to confirm some of them with PCR, there was concerns that there was cross-contamination. So molecular methods haven't been the panacea that they have been for other infections. We rely on molecular methods a lot now, but as Dr. Detweiler said, the bacterial load in late infections tends to be lower, so the sensitivity for PCR tends to be less. You've already seen this. Specificity is important. One of the neat approaches that I think is going to take hold is this whole omics thing. So transcriptomics, this is metabolomics. So it's looking at metabolic signatures in a person's serum or a person's urine, and you can use mass spec to get basically a fingerprint, if you like, of what someone with Lyme disease would have. And you can see that when they use this metabolomics approach, it actually performed very well, and it's on the end of that table there. You can see that the sensitivity in early Lyme in this small study was 99%. The specificity was very high as well. And then as they went further down, you can see that the healthy controls are not, the specificity is still not great. It's 95 and 94%. So although it holds promise, it's still not ready for prime time because they haven't been able to tweak the system enough. So you look at the signature, you clean up what the background is, and you look for what is unique to people with the various stages that they're presenting with their Lyme disease. And hopefully, at some point, we may get to the point where that genetic signature or that metabolic signature will allow us to definitively diagnose that. We heard about reinfection. It's a huge challenge. In Nova Scotia, we've had Lyme disease since well before 2002. First case was diagnosed in 2002, but certainly the ticks have been around for a while. We have the highest incidence of Lyme disease in the country. In Lunenburg County, we have an incidence of over 200 per 100,000. So reinfection is a real problem for us because we can't tell who is reinfected. Right now, you have to sort of pick out extra EM that is not in the original EM, and we know that EM is not always there. So developing a test that will be able to differentiate reinfection from previous infection is going to be very important. And maybe some of the research that Dr. Detweiler and Dr. Fallon's doing that's looking at these overall characterized signatures will be able to do that. Biodiversity, I'm just going to quickly go through some of this. This has always been raised as a question of how does biodiversity affect our diagnostics? There's no question that there is a biodiverse population of Borrelia. And from an evolutionary perspective, I'm not the expert. There's actually other experts within this conference. You can talk to Janet Sperling, for example, who will tell you about the biodiversity of Borrelia in ticks in Canada. And there are unique signatures in different areas. So the question is, if they vary genetically, how much anagenically variation is there, and does that influence testing? Well, there is at least a little bit of data out there from Wormser's group in 2008. There's not a whole lot of data otherwise that shows that the C6 was pretty good at detecting the same amount of people with acute Lyme disease of different RST types, or different genetic variation, if you will. Whereas the two-tier system we know doesn't work. And that may be because the Western blot can be influenced because of these proteins. But the C6 should pick it up, so you should be getting a positive C6 as your initial screen. So I'm going to summarize quickly. I've got 2 minutes left. Poor performance of serology in early infection is well known. We know that it's a limitation. In fact, when I give education talks to physicians in Nova Scotia, I remind them that when someone presents with erythema migrans, that treatment is what is required and not testing. There is no test of cure. Seroconversion can influence the ability of us to pick up serology. So if you treat early, then seroconversion may not actually occur because you've aborted the immune response. Serology can persist from a decade, again, making it difficult to diagnose reinfection. The influence of diversity really needs to be further explored. Some preliminary data says that it's not, that it'll influence the two-tiered system for sure, but the C6 should pick it up. There's no current diagnostic testing for post-Lyme disease syndrome, and I think that the group at Johns Hopkins is doing some great work looking at, again, these metabolomic signatures and some of these transcriptomes to try and predict who that has Lyme disease and gets treated is going to be at risk for getting post-Lyme disease syndrome. So for me, what we need is well-characterized specimens. Convenient samples, as I said, are used for determining sensitivity and specificity in our testing. It's difficult to compare the new tests if the reference method is based on the two-tier system to begin with. So my plea is that we need to really have cohorts where we can follow and get the appropriate specimens so that we can actually do some analysis of the newer methods that are coming down the pipe. We need to have these better defined cohorts. And again, just to come back to the ones that I mentioned first, these are the cohorts that I think we need to focus on. Some of them are more easily definable than others. So with that, I'm just going to end you, and I wrote it down just because I don't know if I was thinking clear in the morning at 4 o'clock, but I did really find it profound to listen to people suffering yesterday. It's clear that many people have suffered, some for years, with chronic debilitating symptoms. I'm a father, a husband, and a son, and I cannot begin to imagine how this has affected your lives. What I've also heard was stories which had a lot of similar features, but also reflected a heterogeneous nature to those that are suffering. There are those that tested positive for Lyme in Canada that could not get testing or acknowledgement by physicians. This is clearly unacceptable. It requires ongoing education of our medical professionals. There is no reason for anyone in this room who has been diagnosed in Canada to not have access to treatment. There are those that have tested negative by Canadian laboratories but tested positive by the IGeneX lab, or other labs, I suppose. I don't know if it's all IGeneX, but that's from where we come from. That's usually the lab that does the testing. There are those of you that are negative by all tests but diagnosed by clinical symptoms alone. To me, I believe that the last two groups of patients are where the primary problems lie. And the problem is it an issue that the tests are not being able to detect the Lyme? Is it they're not detecting another co-infection? Or is it that there is another disease that's being missed? And if it wasn't for people recognizing clusters of arthritis in kids, they wouldn't have found Lyme in the first place. So I wouldn't want to have blinders on to make us not think of the possibility that there's something else causing some of these symptoms. And when I listened to everybody's stories, there were similarities, but there was distinctions. Some people have more cognitive issues. Some people have more neurologic issues. This is a very heterogeneous group. And I think to better define exactly how to move forward, we need to look at the cohorts very closely. We heard a lot of moving stories last night. Some questioned why a cancer patient could access treatment when those suffering with Lyme cannot. One of the answers is that because these treatments have been proven in clinical trials, and those that have no proof are not used by oncologists. While many would see the researchers and doctors who discovered these new treatments as heroes, I would suggest that it is the patients who volunteer to be in clinical trials to test hypotheses on what the best approaches to treatment are the true heroes. Without them, without you, we will not find the answers we need. So is testing perfect? No. There are clear data that states that tests are accurate in detecting Lyme disease based on the serologic stuff that we have shown you. We know that it does not perform well in early disease and can miss up to 50% of the cases. But there is hope in that the newer diagnostic technologies out there will help us develop newer diagnostic tests. But to do that, what I would like to see is support for well-designed studies that examine all the categories of Lyme disease, that we can collect the samples necessary to assess the new diagnostic methods, and in doing so, we can leverage the same infrastructure to learn more about why people are suffering, the pathophysiology of disease. Is it Lyme going undetected? Is it co-infections that are being missed? Or is something that we have yet to adequately describe? Is it the pathogen, the host, or both? These are questions that need to be explored in well-designed studies. And to me, that's what we should be advocating for.